Hello, everybody. Welcome to today's webinar. We're excited to have Dr. Nathan Zasler with us today to talk about the topic of concussive brain injuries. Just a couple of housekeeping items here. We're recording this webinar for future review. And also we ask if you have questions during the webinar, please type them into the chat area, and then we're going to get to as many of the questions as we can at the end of the webinar. And we look forward to chatting with you today. I'm going to turn things over to Kyle at this point, and he's going to introduce Dr. Zasler.
Thank you, Ted. Glad everybody could join us today. I'm Kyle Kinberger, the National Sales Manager for HMR. We're really happy you could join us and listen to Dr. Nathan Zasler. He's a certified brain injury medicine specialist. He's internationally known in the field of brain injury. He's published and written extensively over the last 30 years on the topic of traumatic brain injury, including addressing medical legal issues. He's board certified in physical medicine and rehabilitation and fellowship trained in brain injury and subspecialties certified in brain injury medicine. He is the founder of the Concussion Care Center of Virginia, an outpatient interdisciplinary practice in Richmond, Virginia. He's also the founder of Tree of Life Services, which is a transitional and long-term care assisted living program based in Richmond. And he's been operational there since 1998. So with that, we're going to turn it over to Dr. Zasler for the rest of the presentation.
Thank you very much. Pleasure to be here, and pleasure to be presenting in front of colleagues in the legal community. I hope when you finish this presentation that you walk away with some tidbits that will be helpful within the context of your practice as a lawyer dealing with folks who come in presenting with complaints that you think are consistent with concussion. And we have the Q&A session at the end just to make sure people are aware of that. So if people do have questions, we would appreciate those being submitted and or asked at that point. And on that note, we will go ahead and proceed. As has been noted, this is sponsored by HMR. Our learning objectives for today include understanding the limitations about how we label, diagnose, and treat persons with concussive brain injury, as well as how those things may impact outcome, review recent advances in understanding concussion assessment, differential diagnosis, and recovery course. As you'll learn, that can be highly variable. Learn what is known regarding risk factors for protracted outcomes and persistent symptomatology. And in that context, I'm also going to be discussing ways that clinicians can minimize the risk for protracted symptoms through certain aspects of holistic treatment. And then summarize disability management recommendations for minimizing risk for protracted recovery after concussive brain injury. Some introductory comments that I felt were important to make here. Number one, concussive brain injury, also called mild traumatic brain injury, is very common, and it makes up the vast majority of all traumatic brain injuries. So as an attorney and as a clinician, that's what we're going to see most, not moderate, not severe, but mild injuries. There are significant nomenclature issues and definitional issues that make looking at this research challenging and comparing studies. So that needs to be kept in mind as well. And we'll talk about some of those aspects. There's no consensus methodology currently agreed to for neuromedical assessment or treatment of persons following concussion. So what one doctor does assessment-wise or treatment-wise may be very different from another clinician's practice. There's no consensus on how to differentiate so-called neurogenic symptoms, those are symptoms associated with the brain injury itself, from non-neurogenic symptoms after a concussion. There's no agreed upon neuropsychological testing paradigm for concussive brain injury. So in that context, neuropsychologists may give different tests. There's not a consensus agreed to battery that everybody uses for assessing someone with a concussion. There's no neuropsychological profile that's pathognomonic for concussive brain injury or post-concussive disorder or persistent post-concussive symptoms. The etiology of persistent problems after concussion continues to be debated, and we'll talk about that and amplify more. So if it was as easy as putting a high-tech device on your head and saying, oh, you reached threshold for concussion, we wouldn't be having this lecture. We're not anywhere near that point yet, although there are some interesting advances. So one of the things that I think is important to understand are some of the basics of what the neurological criteria are that are typically used as a basis for saying someone more likely than not sustained a concussion. The Glasgow Coma Scale score, which hopefully everybody is familiar with, is a relatively general way of expressing severity of brain injury developed in the early 70s in Glasgow, Scotland. A number of variables may impact the score. So having been intubated, being on significant amounts of alcohol, things like that can negatively impact the score. Post-traumatic amnesia, that is the period following the trauma that there is a difficulty in memory consolidation, by definition, although totally empirical, is said to not last more than 24 hours, but you don't have to have amnesia to have sustained a concussion. Loss of consciousness, many in the neurological community, and some still do, used to think that loss of consciousness was a critical piece of the presentation, and if you didn't lose consciousness, you didn't have a concussion. But we know that's not true. Mild brain injury or concussion is defined by a loss of consciousness no longer than 30 minutes. Again, it's not necessary to have a loss of consciousness to sustain a concussion, but it does tend to be related, as does PTA even more so, with severity of injury. So the longer your PTA within that 24-hour range, implicitly the more severe the injury. Again, the 30 minutes for loss of consciousness is also empirically derived. One of the things that qualifies as mild relative to GCS is that you have to maintain a GCS of at least 13 moving forward. If your GCS declines from the first post-resuscitation score, then you no longer qualify for the mild classification. So depending on the circumstances, you may have a moderate, probably more likely than severe, although even severe is possible. May or may not have an amnestic gap, and the amnestic gap is a term that kind of subsumes both retrograde amnesia, that is memory loss for before the trauma, and anterograde amnesia, which is more in line with post-traumatic amnesia. So that's amnesia moving forward in time from the time of the trauma. Other acute neurological parameters that should be asked about include dazing, confusion, on exam, the presence of any focal neurological symptoms or signs, postural imbalance, which is a big one, and cognitive difficulties. Concussion accounts for up to 90% of all traumatic brain injuries. We don't know the true incidence as it's probably both underreported and not necessarily kept record of in terms of how hospitals document these types of injuries. Hospital treatment rate of 1 to 3 per thousand, with an estimate of 6 per thousand persons in the general population. I'm going to give you both sides of the coin here, which is my typical MO, and tell you, interestingly enough, that there's a 30% incidence of post-concussive type symptoms in healthy controls. That was work done by Grant Iverson, a well-known neuropsychologist originally from British Columbia, who's now at Harvard. So there's a risk of what are termed false positive diagnoses, which is not insignificant. So just because you have headache and depression or balance problems and sleep difficulties doesn't mean you had a concussion. More than half of all persons with concussive brain injury have no loss of consciousness, about 25% a brief LOC, and about 10 to 15% with more protracted loss of consciousness within the confines of the definition I previously gave you. Males account for more than 3/4 of all patients with concussive brain injury. In part, that's related to risk-taking behavior as well as activities that guys typically participate in more so than women. Persons with concussive brain injury typically receive treatment for other injuries, which makes interpretation potentially more challenging as far as delineating the source of so-called post-concussive symptoms. Some of the key challenges here, legally, clinically, research-wise, include the fact that there's no internationally accepted consensus definition for what we're talking about. There are multiple different definitions across multiple different organizations. There's no evidence-based definition that is uniformly applied in both clinical and research settings. There's no definition currently with strictly objective criteria that is commonly used. I'll talk some about some of the things that have been done and are looking positive for future use. We know from a pretty extensive amount of literature that there are differences in terms of outcome between people after concussion who have unremarkable acute imaging by CT versus abnormal acute imaging by CT. The latter group being defined as complicated concussion or complicated MTBI, which is often ignored in prognosis, but the group that has abnormal findings as a group does worse as far as their cognitive behavioral outcomes compared to those with normal scans. In my experience, and I'll try to differentiate where it's experiential and where it's evidence-based, in the lecture today, there's a significant rate of misdiagnosis, both in terms of people being told they don't have a concussion when they do, and people being told they do have a concussion when they don't. Obviously, people can have concussions and still have an array of symptoms following the concussion. The challenges are those symptoms still related to the neurological event of the concussion or something else. And we'll talk about that a bit further. One of the ongoing controversies has been what language we use to describe this condition and the problems that occur after it. Post-concussive syndrome is pretty historically entrenched in the brain injury literature, but it's really a misnomer. A syndrome, if you look it up in the dictionary, is a consistent set of findings associated with a condition with symptom linkage and coupling of symptom resolution. There's no consistency to the signs or symptoms of concussion, and there is no symptom or set of symptoms that are a priori diagnostic of concussive brain injury. So preferred options may include terms like post-concussive symptoms or post-concussive disorder, which was used in the prior DSM classification, but interestingly is not in DSM-5. So symptoms are highly variable across patients, which makes the syndromal designation, at least in part, inaccurate. Some of the more common symptoms following concussion include headache, which is by far the most common physical symptom, cognitive difficulties, visual impairment, behavioral changes, sleep difficulties, smell loss, tinnitus or buzzing in the ear, dizziness, and imbalance. I would note that as far as cranial nerve impairments, and I think this is an interesting caveat, that most examiners don't bother to assess smell, yet olfactory impairment via cranial nerve 1 is the most common cranial nerve impairment that you see after concussion. So it's very important to assess it, not just to identify the impairment, but because that impairment also is a marker of frontotemporal contusional injury. There remains controversy regarding the origin of so-called post-concussive symptoms. Many types of post-concussive symptoms are not due to the concussive brain injury itself, headache being a prime example of that, which is typically cervicogenic in etiology, meaning coming from the neck. And we'll talk more about that in the literature that supports that. Just because someone had a CBI history does not mean that all their problems are secondary to the same, although some may be, or alternatively none may be. I like to recommend that people think about the 3 C's in the context of differential diagnosis, and the 3 C's being injury to the head or cranium, injury to the neck or cervical injury, and lastly and most importantly, injury to the brain or cerebral injury. It's a nice way to keep in mind the things that can cause a similar set of symptoms across those 3 C's. Reporting of symptoms is individualized, and the literature suggests that it represents the summation of multiple variables, as I've listed here. You can see all those. I won't read each one, but lots of things can affect how you report symptoms, how many symptoms you report, how severe you report the symptoms, etc. Nancy Carney out of Oregon did a really nice study that was published a number of years back in neurosurgery, and it was really one of the first studies that looked systematically at what are the objective parameters that can be used to best define whether or not somebody had, with a degree of medical probability, a concussion. And they came up with these 4 criteria: observed and documented disorientation or confusion immediately after the event, impaired balance within 1 day post-injury, slower reaction time within 2 days post-injury, and or impaired verbal learning and memory within 2 days post-injury. I haven't seen, interestingly, any follow-up to this study, which I think was a pretty landmark study, but really needs further follow-up and expansion and multi-center prospective controlled research. A group published a paper in Journal of Rehabilitation Research a few years back, looking at multimodal neurophysiologic assessment to confirm a diagnosis of mild TBI. Again, haven't seen follow-up work on this either, but preliminary validation at that time had been conducted of a battery of tests, including eye tracking, balance, and neurocognitive testing that they called CBIAS as the acronym. This type of system is not ready for primetime use, but once further advanced, may offer a comprehensive, multimodal, and objective concussion assessment solution that is both time efficient and efficacious at differentiating individuals with and without a history of MTBI. A systematic review performed in 2017 and published in British Journal of Sports Medicine concluded that whenever possible, assessment should incorporate evaluation of multiple systems, not just a standard bedside neurological exam. They emphasize the need to assess vestibular, oculomotor, neurocognitive, psychological, and cervical aspects of the exam. On that note, the neck has been shown to be a significant contributor to post-concussive symptoms and persistent post-concussive symptoms. I have been touting this for probably close to 20 years, but now there's literature to back me up. Neck injuries or whiplash-associated disorders are a common comorbid finding in persons with concussion, as I'm sure you're all aware. Neck injury and associated dysfunction of cervical structures and systems may be a cause of and/or compound or perpetuate neurogenic post-concussive symptoms. The cervical spine has been proposed to play an important role in persistent symptoms. There are several studies supporting that, but this idea is largely untested. Many authors suggest that the brain is unlikely to be the only source of ongoing symptoms, and other contributing sources such as the cervical spine are likely contributory. Consistent with this view, Ellis in 2015 and his research associates proposed classifying concussion into three broad categories: physiological, which are brain-related symptoms; vestibulo-ocular, which have to do more with isolated vestibular and visual system impairment, the two systems being highly interconnected; and cervicogenic post-concussive disorders, meaning cervical injury from whiplash resulting in symptoms that you see following concussion. Kennedy in 2017 showed that pain on manual segmental testing appeared to be a key feature of the cervicogenic component to post-concussive symptoms. Cervical treatment was a benefit in modulating the symptoms. There's also some interesting literature on the role of suboccipital musculature, that's musculature at the base of the neck, where the head attaches to the neck, in particular referencing the rectus capitis posterior minor, which may impact symptom severity and recovery due to so-called dural connections. So there are anatomical connections between the upper neck and the brain that previously had not been identified, first described by Hack in 1995. Pathology of the myodural bridge likely contributes to persistent post-concussive symptoms. Moving on from the neck comments, when we look at the natural history of concussion, and it's very important to specify here that most of this talk is going to be referencing single concussions, not multiple concussions or repetitive concussive brain injury, which is really a different animal. So after a concussion, neurologic and functional outcome of uncomplicated CBI, generally very good. Most recover within 90 days. Recent work suggests that physiological dysfunction may outlast clinical measures of recovery. So you may look recovered on neuropsychological testing, balance testing, bedside testing, but physiologically you're not. That's not always true, but it can be true. It is currently not possible to define a single physiological time window for recovery following concussion. Important to keep in mind. There is still debate regarding how to segregate symptoms to confirm with certainty, or with at least medical probability, which I should have used there rather than certainty, that they are in fact post-concussive in etiology. Not my term, but a term that's been in the literature for a number of years, the so-called miserable minority, those who don't get better and have persistent post-concussive symptoms. The cause remains debated. Clearly, some of that is neurogenic, but some of it's not. Greater age, education, and male gender tend to do better. High school athletes, particularly girls, are at greatest risk for persistent symptoms. Chronic problems are generally not directly related to the original injury, but may be misdiagnosed as such. A small percentage, 5% or less, may have long-term functional difficulties due to the CBI itself. Again, a lot of that has to do with how they got treated or not treated up front and early, as we'll talk about shortly. The MTBI outcome literature is confusing, and I will be the first to acknowledge that. These are recent studies that kind of give you a different view when you look at one result versus the other. Grant Iverson and colleagues published a paper that was a reanalysis of a scoping review by McInnes on outcome and found that a single MTBI was not associated with a high incidence of chronic cognitive impairment. A large study called TRACK-TBI found that most patients with MTBI presenting to US level 1 trauma centers, so again, you're looking at people probably with more severe injury because they did go to the hospital, reported persistent injury-related life difficulties at 1 year post-injury based on subjective reports. So this was totally telephonic, no exam was involved, no testing. Orthopedic injury control group was included in that study. Interestingly, those who had positive CT scans, not surprisingly, reported more impairment compared to those with negative scans, consistent with that concept of complicated versus uncomplicated MTBI. When you look at cognitive symptoms that are self-reported by patients from 2 weeks to 3 months after a brain injury, we see that there are improvements in subjective cognitive complaints concurrent with improvements on other subjective metrics, but these improvements have been found to not be related to objectively measured cognitive function. Question is, why? We don't know the answer. A recent longitudinal control cohort study showed that cognitive reserve, but not post-concussive syndrome, again, I put it in quotes because I'm encouraging you not to use that phrase, was associated with cognitive outcome after an MTBI. So they looked at cognitive reserve, meaning how good you were before your injury through specific neuropsychological measures that are resilient to being affected by brain injury, and then looked at outcomes relative to one versus the other. So an interesting finding and very recent study in Archives of PM&R. Natural history of recovery. There's many questions here in terms of what impacts how you recover from a concussion, including, and this is Zasler commentary here, just for everybody's notation, the impact of non-concussive brain injury post-traumatic impairments on recovery. So if you smack your head against the window, do you expect somebody like that to have headache and things that might produce chronic headache? The answer is yes. That has nothing to do with a brain injury, though, as one example. Impact of secondary gain incentives on concussive brain injury recovery. Again, as a group of plaintiff attorneys, it's important for you to know that there is a large literature in the evidence-based literature that shows that secondary gain incentives, whether work comp, SSDI, personal injury litigation, has an impact on patient behavior and reporting. as well as recovery time following these kinds of injuries. What's the impact of diagnostic labels? So I'll talk about this, but if I called something a head injury versus a concussion versus a traumatic brain injury, if you were being seen as a patient, which would you consider the most innocuous versus the most significant? I think what terms we use does make a difference. What's the impact of nocebo effects and negative expectancies? Nocebo effects is basically the opposite of placebo. So if you think having a concussion is going to mess you up for the rest of your life and you go into the injury with that perception, then that can promulgate symptoms and make your recovery more protracted. What's the impact of stress? This is an undervalued area of exploration in terms of the evidence-based research. We know a lot of these folks who aren't back at work yet are under financial stress. Their legal issues may be stressing them. Stress is not a good thing. I think everybody knows that, but after a brain injury, it's even more not a good thing. So again, something to keep in mind. What's the impact of attention gained by illness and disability? The impact of pre-injury personality on recovery. We know that does make a difference. Impact of misattribution bias, anger, loss aversion, all important in this context, as are how resilient the patient is. There's a lot of research recently on the significant correlation between higher levels of resilience and better outcomes after TBI more generally. What is the impact of somatic symptoms? So people with dizziness, headache, tinnitus tend not to do as well as people who don't have those kind of physical symptoms. And what's the impact of affective symptoms, given the high occurrence of anxiety disorders, depression, PTSD in this patient population? Clearly that can impact them in more than one way. For example, all those things, if severe enough, can adversely affect cognition. They can adversely affect sleep, among other aspects of our function. Outcomes, most evidence indicates the presence of cognitive deficits in the first 2 weeks post-injury. Again, with the caveat that you probably see the group of folks who don't get better quickly, but when you look at all comers, most do well over a relatively brief period of time. Some evidence suggests that complete recovery, both clinically and physiologically, may take 6 months or more. A small number of studies indicate that CBI increases risk of psychiatric illness and suicide. We can talk more about that if anybody's interested. There are some methodological concerns that I have about the suicide issue. There is no consistently agreed to definition of the time frame for assigning the term persistent relative to continued symptoms following concussion. If you look at the different literatures, there's different definitions. So in sports-related concussion, it's been defined as greater than 10 days to close to 1 year. Based on the Berlin 5th ICCS, persistent post-concussive symptoms is greater than 10 to 14 days in adults and greater than 2 months in children. And that's, for those not familiar with it, the last big sports concussion meeting. In civilian concussion literature, some have used a time frame of 3 months for persistence, others 6, and yet others 12. Persistence of symptoms following concussion should not inherently imply the cause is the original concussion, although it might be. Detailed multimodal assessments are critical to come to that conclusion that they are in fact causally related and apportionable to that original injury. How much does brain damage account for persistent symptoms after concussion? Again, our tools are only as good as the sensitivity and specificity of those tools. And we have newer ways to image the brain, including morphometric imaging connectivity imaging after concussion cannot be assumed to be pathognomonic for concussive brain injury related brain sequela. Structural imaging via MRI as well as morphometric brain imaging have not been found to be significantly associated with greater post-concussive brain injury symptom reporting. On the other hand, DTI, or diffusion tensor imaging abnormalities, have been shown to be associated with cognitive impairment after concussive brain injury, including attention, memory, and executive function. The extent to which actual brain injury following concussion contributes to persistent symptoms remains unclear and debated. Predicting outcome via MRI biomarkers. This is very recent, hot off the press literature. Recent data generated through a systematic review noted scant evidence and considerable methodological heterogeneity among studies which mainly assessed brain connectivity MRI biomarkers via three main methodologies: global functional connectivity, default mode network, and fractional anisotropy. The authors nonetheless concluded that brain activity MRI biomarkers obtained within 1 month of the injury may be potentially useful in predicting TBI outcome, although they emphasize the need for further studies. What causes PPCS? As I think I've already implied, there's a dearth of good research that addresses symptom origin per se and differential diagnosis after concussion. The underlying biology is poorly understood, and we must consider brain-based as well as extracerebral symptom generators. Such research also needs to consider issues of effort, symptom and performance validity, as well as response bias assessment findings. This was an interesting poll that I felt was worth including in this talk because it tells us a lot about what the lay public thinks about concussion. This was a poll in 2012, US adults ages 18 and older. 24% thought a concussion would change their life forever. 72% believed that brain damage from concussion was permanent. 80% believed that one could only lessen symptoms after concussion and that one would never fully recover. 81% were not comfortable that they would know the steps to manage a concussion if they sustained one. Goethe said, "We see what we look for what we know." I think this is very true for this condition. Factors that need to be assessed in causality when you're looking at a case or a clinician that you have requested to see your patient is looking at the case. The consistency of complaints with expectations. Examine the symptom presentation over time. Does the story change? So looking at records serially and seeing if the story is the same or not. Check for other injuries, both physical and or psychological, that may compound disability. Look at whether tests were appropriately ordered and interpreted. Check performance and symptom validity. Review acute record clues on injury severity and or events that may have prognostic significance. The temporal relationship of subjective complaints with objective findings is also important. Physical examination findings, including elemental neurological exam, appropriate cognitive screening, and psycho-emotional assessment are also important. And the earlier that gets done well, the better in terms of having a record that serves as a foundation for a claim of concussion. Corroboration as possible, the more independent, the better. So if you had an eyewitness to the accident, that's pretty critical that you and your experts talk to that eyewitness to know what exactly happened. Some of the historical markers that are permanent when taking a concussion history, or pertinent when taking a concussion history include what the patient's last memory prior to the event was, what their first memory after the event was, documented or observed alteration of consciousness. Did the person remember losing consciousness? If they tell you they do, you may want to let them go consult with another lawyer, because nobody remembers losing consciousness. Duration of amnestic gap relative to injury incurred, does it make sense or not? What did the initial imaging show? Were medications, alcohol, or drugs on board at the time of initial assessment? There is a huge list of things that may present and look like brain injury, and we need to keep these in mind collectively, you as lawyers, me as a clinician, and certainly other clinicians seeing these patients. This is not necessarily an all-inclusive list, but some of the things that can be concurrent and causally related to a traumatic injury. Some may not be related, but that's part of the puzzle that needs to be figured out by the clinician. Again, I won't read through all of these, but I have 2 slides here for your consideration as far as things that should be taken into consideration in the context of differential diagnosis. So this process is not a 5-minute process. It requires time on the part of the clinician in terms of record review, in terms of examination, and certainly requires a nuanced understanding of the realities of how to assess these kinds of patients and all the things that can contribute to symptomatology. Risk factors that have been found to be relevant for predicting more protracted symptoms include dizziness at the time of injury, migraines, mood disorder, early anxiety symptoms, playing certain positions, mainly football, poor pre-injury health or mental health, more extracranial injuries, symptomatic at 1 month post-concussive brain injury, symptom and neurocognitive clusters, particular ones tend to predict protraction of symptoms, and premature post-injury return to work or play / exertion. The most consistent predictor, however, of slower recovery is the acute and subacute symptom burden level. So the more symptoms you have and the more severe they are, the longer you're going to take compared to somebody with less symptoms and less severe symptoms. Development of subacute problems involving headaches and/or depression are likely risk factors for persistent symptoms. Pre-injury mental health problems appear to put one at greater risk for having persistent symptoms. Majority of studies have shown an absence of an association between prior concussion, loss of consciousness, and amnesia relative to worse clinical outcomes. Attention deficit hyperactivity disorder or learning disability do not appear to be significant risk factors for delayed recovery, although they used to be thought of as being so. But recent work by a number of clinicians has found that to be the case. Studies overwhelmingly do not show an association between a personal history of migraine and worse clinical outcomes. So only developing migraine post-injury is related to a worse clinical outcome. There is some evidence that those who are in their teenage years, as I mentioned before, particularly while in high school, might be most vulnerable to develop persistent symptoms, and women tend to do that more frequently than men for a number of different reasons. There's mixed evidence for all potential predictors of outcome. This was a nice analysis in the article by Iverson, Gardner, Terry Ponsford from 2017. And you can see where history of concussions, there's literature to support that it doesn't, and literature support that it does impact persistence of symptoms. Age, a minority show that it predicts longer symptom duration. What are the ones that look strongly more predictive? Sex, certainly. Personal migraine history, you can see that no is much more supported than yes. ADHD, strongly supported that it's not correlated. Loss of consciousness leans towards not being correlated. PTA leans towards not being correlated, but it's a mixed bag. And then greater early symptoms, that's probably the most disparate scores, showing clear evidence that it predicts persistence. There are likely biopsychosocial influences on the duration of post-concussive symptomatology. The fear avoidance model has been proposed as one mechanism that may be responsible for persistent symptoms. It includes issues of catastrophizing thoughts and fear avoidance behaviors. There's a high correlation that's been shown between fear avoidance behaviors and persistent symptomatology. Concussion and sex, does it matter? Well, there's some interesting comments here that I'll try to go through relatively quickly. There are clearly differences in anatomical structure between men and women. Neck anatomy differences likely are a significant influencer of risk for concussion thresholds and tolerance. Guys have bigger, thicker necks, typically shorter necks. Women have less muscular, typically longer necks, which puts them at increased risk for increasing that fulcrum when forces are applied to the neck and head. There are differences in male and female neuroanatomy that may be relevant to outcome that have yet to be explored, including things like differences in brain size, differences in gray versus white matter between males and females, sex differences in terms of how the corpus callosum, which is one of those areas that's prone to shear injury, might respond in males versus females, and males more cylindrical and females more bulbous. Males have larger diameter fibers and cross-sectional areas in the corpus callosum than females. Females, interestingly, have more fibers in the corpus callosum than males and tend to utilize both hemispheres for most tasks, while males are more lateralized. Given the vulnerability of callosal structures to strain forces, it stands to reason that interhemispheric communication may be adversely affected, and this could be one anatomic vulnerability that explains the higher incidence of symptom reporting in females. There are some prediction models that have been worked on. We're not at a level yet where they can be used clinically. The severity of the concussion has been shown to have little long-term prognostic value. Most robust prognostic factors included pre-injury mental health and early post-injury neuropsychological functioning on this particular set of studies. And then women and adults with early post-injury anxiety also tended to have worse prognoses. A new model based on synthesis of existing models with the addition of ER data found that female sex, neck pain, 2-week post-concussion symptom burden, as well as PTSD were all deemed to be significant predictors of delayed recovery, but the model warrants further validation. Prediction research should be improved by standardizing definitions, which is a problem with them currently. Not their fault, but the field hasn't standardized the definitions, and data collection methodologies. How do we treat persistent post-concussive symptoms? Remember that it does not reflect a single underlying pathophysiologic process in most patients. PPCS describes a constellation of post-traumatic symptoms that may be linked to coexisting and/or confounding pathologies. A multimodal clinical assessment is crucial to optimize accuracy of diagnosis and identify the various processes involved in the presentation, primary, secondary, and tertiary. Treatment should address specific pathologies as opposed to just subjective symptoms. So when I see a diagnosis, I'm going to go off kilter here a bit. When I see a diagnosis in a medical record of post-traumatic headache or post-traumatic dizziness, those are pretty garbage can terms as far as I'm concerned. They don't tell you anything about how to treat it or what the cause is. So headache can be due to multiple different things, at least 7 to 8. Dizziness can be due to at least 6 different pathologies following trauma. We need to be more specific in how we delineate those diagnoses. So it may be dizziness secondary to perilymphatic fistula, or benign paroxysmal positional vertigo, or headache due to cervicogenic referred pain and greater occipital neuralgia versus migraine, whatever. How do we treat? Again, education is important. Early modulation of pain, sleep, and emotional functioning is critical. Symptom-limited aerobic exercise and cognitive activity have also been found to be critical in terms of optimizing recovery and shortening recovery timeframes. Targeted physical therapy is clinically indicated. With a good physical therapist, a doctor can do a lot. And not all physical therapy, I will remind everybody, is created equal. So there are therapists who really know what they're doing, and there are therapists who do PT for 4 months and don't really get anywhere. So important to keep that in mind. Cognitive behavioral therapy is clinically indicated. Pharmacotherapy, meaning treating with medication only when needed. Goal is to avoid over-medication or over-medicalization of treatment. Pharmacotherapy is particularly important in terms of pain and sleep modulation, but it's also a primary tool, or at least in your top 2 or 3 tools, for affective difficulties like anxiety, depression, PTSD following these kinds of injuries. Treat in as interdisciplinary a fashion as possible. How do we minimize symptoms and functional disability? We get patients in quickly for prompt assessment and treatment with good differential diagnosis. Be cognizant of the language you use to describe the condition for the practitioner as well as for the lawyer. Educate early on regarding typical recovery, dispel misunderstandings, listen and acknowledge. In this day and age, most clinicians don't take the time to do that, unfortunately. How do we convey information is critical in terms of how people recover. How we label the injury may make a difference in outcome, as I discussed before. How we convey prognosis may affect recovery, both in terms of rate and degree. What materials we give to the patient or family may impact recovery. How we apportion complaints to the injury versus to other factors may impact recovery. How we interpret tests may impact recovery. I'm sure you've seen 3 clinicians take the same test and interpret it differently. Earlier and more thorough examination and differential diagnosis followed by focused treatment gives you the best outcomes. Addressing pain, psychological responses to injury, and difficulty sleeping, as I noted before, as early as possible. Focus on abilities, not disabilities. Early resumption of physical activity has been shown to be associated with lower rates of PPCS, as has progressive aerobic exercise. Change I can't ideation to I can or I will. Avoid catastrophization and fear avoidance behaviors through monitoring and as needed counseling referrals. Provide general concussion education information to patients and families. with the caveat that that information should be chosen carefully. Cognitive screening and neuropsychological testing is clinically warranted to ameliorate concerns and or direct reentry recommendations or lack thereof if they remain significantly impaired. If symptoms are more chronic, look more closely at pre-injury status, risk factors for protracted symptoms, and symptom differential diagnosis. Avoid advocogenic perpetuation of symptoms as well as over-medicalization as possible. Remember that people with secondary gain incentives are more at risk for PPCS. Need to identify this earlier than later. Going back to the second comment, the issue of over-medicalization sometimes becomes controversial because I've certainly seen patients in my practice over the years who've been to 6, 7 doctors before they saw me, and they went to different doctors because they weren't getting better and the treatments being administered weren't helping their complaints. So you can't call that over-medicalization. We're calling over-medicalization doing too many tests, treating with too many medications for things that are not clinically appropriate. Get patients to clinicians with solid differential diagnostic skills who know concussion as well as WAD or whiplash-associated disorder. Avoid sending patients to clinicians who only see concussion, so-called blinders-on approach, or tend to be fatalistic regarding prognostication. Avoid sending patients to clinicians who don't believe in concussion as a clinical phenomenon. Yes, there are people out there like that. Avoid sending patients to doctors who don't perform a hands-on exam. Many of the headache patients that I see in tertiary referral, when I ask them to lay down and start palpating their head and neck, they go, "What are you doing?" I say, "I'm examining you." And they say, "Well, no one's ever done that before." That's a scary thought. Avoid sending patients to clinicians who advocate for long-term therapy services after single concussive injuries. Symptom follow-along and monitoring is critical. Speak with employers to facilitate, if you feel someone's ready to go back to work, earlier work reentry, even if modified. What irritates me is that a lot of employers will say they can only come back if they have no restrictions to full-time duty. And the literature clearly shows that that protracts unemployment, and that returning to part-time work, even if modified, tends to be a much better way of getting patients back to work earlier and then being more successful over time with full work reintegration. Always consider coping resources, stress tolerance, and personality type in context of response to concussions, real or perceived impairments. Advocate for counseling. Many insurances don't like when a doctor refers for counseling, but there's significant experience in literature to show that adjustment counseling, cognitive behavioral therapy, psychotherapy, PTSD psychological therapies, among others, can be very helpful in this patient population depending on their specific psychological issues. Know docs who know brain injuries. Specialty is generally less critical than knowledge and scope and depth of training in brain injury medicine. Ideally, and I'm going to acknowledge I have a bias as a physiatrist, but I think physiatrists tend to get the bigger picture and approach evaluation and care utilizing a holistic biopsychosocial model. They also tend to have a larger assessment and treatment skill set than neurologists and psychiatrists. Avoid capitated and managed care clinical services if at all possible, as they do not lend themselves well to caring for complex problems such as those seen with TBI, including post-concussive care, particularly in patients with more chronification of symptoms. Look for docs who are subspecialty certified in brain injury medicine, whether physiatrist, neurologist, or psychiatrist, and regularly see these types of patients. If not previously treated by a specialty program, consider referral to either an outpatient ABI day neurorehabilitation program or a specialized transitional neuro rehab program with expertise in post-concussive care and differential diagnosis for those patients who aren't getting better in a timely fashion or have persistent, more significant symptomatology that's causing secondary complications, including depression, anxiety, etc. Consider a peer review for advice on case legitimacy, clinical care, prognosis, causality, and apportionment, among other potential issues. Consider, for your more complex cases where you're not sure what's going on, a medical legal evaluation by someone subspecialized in brain injury medicine. Use your community resources as well as local brain injury groups and association to network with qualified providers for your cases. Now, some of you, depending where you are, you may not have clinicians who are appropriately qualified to optimally treat these kind of patients, and that's just a reflection of the relative uncommonness of people. There's now, I think, 800 or 700 brain injury certified physicians in the United States, but that leaves a lot of places not covered by specialists. In conclusion, you must know who the person was before the injury to fully understand how they respond to concussion and related consequences. Always try and get pre-injury records, including standardized academic testing. Talk with corroboratory sources, not just regarding the initial injury circumstances, but sometimes family makes a much better testifying expert than a doc who comes in who only saw the patient once, but the family's living with them and sees how their function has changed as a consequence of the trauma. Stay abreast of literature. Realize that assessment of causality and apportionment in these patients takes time and an eye to detail. Remember that most persons with a single concussion do well neurologically and functionally with time. Good early assessment and education is key to minimizing longer-term problems. Identify and treat physical complaint generators as early as possible. Address psychological sequelae as early as possible. Encourage early rest. No more than 3 days is what's typically recommended, followed by graduated increases in aerobic exercise and cognitive activity along with symptom monitoring. So if they start exercising or doing cognitive tasks and their symptoms get worse, they need to back off. Educate regarding the condition, provide compensatory strategies, avoid premature work, sports, and/or school reentry. Earlier return to work, as I noted, even if the patient is at a decreased workload, results in better return to work rates in the long run if the patient is ready for any level of work reentry. Persistent PCS can generally be avoided if the practitioner stays focused on thorough assessment and differential diagnosis and provides timely and appropriate treatment for same. Just to mention, brief plug, I do educational lecturing. Most of my lecturing is to clinicians, not to lawyers, but I'm happy to lecture to lawyers, both plaintiff and defense bar. I try to be even-handed. I think it's important that all lawyers understand the science of brain injury, not just plaintiff attorneys. Medical legal consultation services and clinical consulting through either my outpatient practice at Concussion Care or my transitional and long-term care program for persons with acquired brain injury at Tree of Life. On that note, I will conclude. I actually did pretty good on the time. I thought I'd go over more, but here we are at 4:06 or 4:04. That's my email. If people have questions and would like to email me, feel free to do so. Thank you all very much for attending today. I hope it was helpful.
All right, thank you, Dr. Zasler. And I've got, there are several questions that have come in. Let's see, the first is, it was a question, it says, from your viewpoint, there is no clear delineation of how long a brain injury will last, and that there are multiple studies with no uniformity if one is suffering from TBI or how long it will last. I guess it was a, is that correct?
I'm not sure I totally follow the question, but you need to look at various parameters to gauge severity, as I discussed. And if we're talking about concussion specifically, there are patients who can have permanent long-term problems as a result of a concussion, but those numbers are probably pretty low. Again, the literature is not all on the same page, if you will, regarding what % of folks have ongoing persistent symptoms, which again, the question is, are the symptoms related to the initial brain injury or physiological dysfunction or measurable objective impairment? So you'll see disparities and different results on studies, but when you look at the collective information, most patients typically are functionally recovered by 6 months and certainly 12 months post-injury, with a small percentage having symptoms following that. Excuse me.
Okay, thank you. And then there's another question. It says, why is it that so many of this attorney's clients with whiplash and cervicogenic injuries go on to have chronic headaches?
Because they're not being treated properly is probably the answer. If the diagnosis was cervicogenic headache, there's multiple different types of headache treatments that may be relevant. Without knowing details, I can't really answer the question, except to say, if in fact they have cervicogenic headache, generally that's a very treatable condition. In that context, I'm not necessarily saying you absolutely abate all headache, but you can certainly end up there, but at a minimum, you're modulating pain symptoms, making somebody more functional, increasing neck range of motion, decreasing pain, decreasing use of pain medication, etc.
Okay, thank you. And then here's another, it says, can you talk about VNG testing?
Sure.
What to look for, and is it helpful for diagnosis as a good alternative to CT or MRI?
Well, it gives you totally different information than static imaging via CT or MRI would give you. Video nystagmography, which is what VNG stands for, is a methodology to assess for a condition called benign paroxysmal positional vertigo. And the main part of that test, although there's multiple parts that is diagnostic of that, is asymmetric caloric responses. Again, there are different reasons why that can happen, but that test is the sort of gold standard for assessing the dizzy patient who is suspected of having BPPV.
Great, thank you. And then we've had just several questions about just the chronic headaches. So we have another one here asking if there's a cure. Are there cures for chronic headaches? And then there was another about the best treatments for post-concussion migraine headaches. I think those are probably similarly related.
I'll tell you what, because that's a lecture in and of itself, but I'm happy to give it another time. But as I think I mentioned in the lecture, there's multiple reasons people can have headache, and in most situations, headaches are mixed. So you may have a combination of cervicogenic headache and migraine-like headache, or neuritic headache with tension headache, or TMJD-related headache, temporomandibular joint disorder from the trauma, which can also cause headache with neck-related headaches, cervicogenic headaches. I was going to offer, I don't know if this is amenable to you, to share with you some literature of chapters that I've written within the last couple of years on post-traumatic headache, if any of the lawyers are interested.
Oh, I think that would be wonderful. Yeah, we could put that on our site or send that directly out to the attorneys. Yes, I think that would be great. And let's see, here's another, it says, what can you add about second accident injuries?
They can certainly complicate things. You know, if you're talking about a subsequent concussion, that's one conversation. If you're talking about somebody who had a concussion with associated traumatic injuries or polytrauma, and then sometime after that, 6 months, 12 months, 18 months, is in another accident, a fall, a motor vehicle collision, etc. If I see somebody after that, and then there's these two accidents, I really rely heavily on the medical record, which a lot of times isn't that great in terms of objective documentation, testing, etc. So when that happens, it becomes generally pretty challenging to segregate out what's from the initial injury, what's an exacerbation or aggravation from the initial injury versus the second injury. And I'll leave it at that since the question was pretty general.
That sounds great. I appreciate your, let's see. Oh, here's one more. From your research findings, is there an average percentage you assign to the secondary gain for symptomology of patients?
No, because every patient's different, and not every patient who's in litigation certainly has secondary gain incentives or performs poorly on effort testing or validity testing in general. But if you don't test for validity, it's like when we do a urine, we look at the temperature. That's a validity check. When we examine patients, it's our obligation as a clinician to make sure we're getting valid results, so that if someone has a weak arm, is that because of shoulder girdle problems from a whiplash injury and a seatbelt injury, or is it because of brain injury and they have paralysis in the arm? That's part of being a good clinician, is understanding how to do those, make those differentiations in the context of validity assessment globally.
Excellent, thank you for that.
And just as a note, I've written on that as well, if any of the attorneys are interested in that literature.
Okay, that sounds great.
Exactly.
Yeah, I think it might be helpful if we were able to put together links to those articles, and we can post those and send those out in our follow-up email after this webinar. I think that would be great. And I think that is the end of our questions right now. So I really appreciate your time, Dr. Zasler, and I hope everybody that attended this webinar learned something new. Everybody have a great rest of their day.
Stay safe.